Welcome to the Ostomy and IBD Life show. My name is Elaine O'Rourke. I am your weekly host here, and we get to talk about all things from the mental to the emotional to the physical aspects of having an ostomy or Crohn's or colitis. I also work with people privately through my different programs. The one for ostomies is called Surviving to Thriving, Overcoming Ostomy Challenges so you can live a fulfilling life. And I also work directly with people with Crohn's and colitis through another program. Now, this week, I am really excited because I have Nurse Beth-Ann Norton coming on to talk about J pouches, which is another type of ostomy, but it is an internal ostomy. So she is totally proficient in this topic, and she is also has been working at the Crohn's and Colitis Center at the Brigham and Women's Hospital for years, and I know her through my past. She was one of my nurses also back when I had Crohn's disease. But firstly, before we bring her in, if I could just ask you, if you are on YouTube, to subscribe or to give a like on my YouTube channel, which is Elaine O'Rourke Yoga, Ostomy and IBD. I'm also on Instagram under Elaine O'Rourke Yoga, and on Facebook for this business page, it's under Ostomy and IBD Life. It's also really helpful for others if you found this information valuable to share it with anyone you know that is going through Crohn's, colitis, or has an ostomy. Because the more people that know, then we are all then helping others, and that's what we're here to do. So I'm going to bring Beth-Ann into the room, add her in. Hi, Beth-Ann, and thank you so much for joining us this evening.
Thank you for having me. I'm really happy to be here.
So, Beth-Ann, you've been working in the Crohn's and Colitis Center for years, and even before the Brigham and Women's Hospital. I know you're over at Mass General Hospital for years, but can you tell us a little bit more about your background?
Sure. So I'm a nurse practitioner, and I started my career here at Brigham and Women's working in colorectal surgery. And I was in that setting for 4 years, which is where I learned a lot about J pouches. But then I went over to Mass General to work at the Crohn's and Colitis Center there. I was there for 8 years. And then I was down at Mount Sinai to help them develop an inflammatory bowel disease center in New York City. I was there for 2 years, and now I've been back to Boston, where I started my career at Brigham and Women's working in the Crohn's and Colitis Center here. And I've been back for almost 9 years now.
9 years. All right. Wow. I didn't realize that you even went outside of Massachusetts for a while. Well, we are very glad that you are back here.
Glad to be back.
So let's just get right into it. Can you describe, because I find it so hard because I have like the physical ileostomy. So I've had my ileostomy now for 15 years due to Crohn's disease. So I'm just fascinated by a J pouch because it's internal. So can you kind of like describe what a J pouch is and what its function and how it kind of works?
Sure. So I know that you have some slides from a talk that I gave. So if you want to bring up the picture of what the J pouch looks like initially, post-operatively, that would be great so that people can see it and understand. So generally what happens in patients who have ulcerative colitis or familial polyposis, or if someone's had significant trauma to their abdomen, they can have this surgery. So generally what happens is the colon is taken out in the first surgery, and people end up with a temporary ileostomy, which you can see in the picture. You can see feces pass through stoma, the ileostomy. And below it is a J pouch that has been created but is not functional yet because all of the stool is coming out into the appliance. Then about 8, maybe 10 weeks later, depending upon the health of the individual, they will go back for a second surgery where the ileostomy is taken down and sewn to the top of that J pouch, and then it's internal, and patients will actually start to have what we call J pouch movement. They'll stool through their anus once again. So again, we do this for people who have ulcerative colitis who failed multiple medications, We do it for patients who have familial polyposis, who are at high risk for cancer. And we do it in patients who've suffered some sort of a blunt force trauma to their abdomen and their colon has been compromised because of that.
Oh, I see. So you actually, if you have a J pouch, you still go to the bathroom through the rectal area.
Correct. Right. The rectum is gone, but the anus still functions. The muscles in the anus still function.
So you said for people more so with ulcerative colitis and for people who have Crohn's disease, this is not an option.
It's really not an option unless we know that the Crohn's disease is truly, isolated to the colon only, and they don't have any perianal abscesses, so no perianal disease. However, we found that when we've done that with patients who do have Crohn's disease only in their colon, sometimes they end up having a J pouch failure and end up with a permanent endoleostomy eventually anyway.
Ah, right. So it has to be contained to the colon. Now, for someone with ulcerative colitis, this would be a good match, but it would have to be. How would they know that's the right fix compared to having an ileostomy, say?
Okay. So, I mean, again, that is a very personal decision with their surgeon. But sometimes we are unable to give people a J pouch because of their advanced age, because we're worried about them developing incontinence, because there's a lot of pressure behind that J pouch, if you will. So if people had a lot of problems, if they're older, we usually think about people over the age of 65 to 70. If they're older and they had a lot of incontinence while they were flaring with their ulcerative colitis, we would be a little concerned about offering them a J pouch and would recommend a permanent ileostomy.
All right. So let me just get this clear in my head. So if you have a J pouch, you have the colon, the large intestine actually removed completely.
Mm-hmm. And the rectum is removed as well.
And the rectum is removed as well.
And that J pouch is made out of about 1.5 foot of small intestine that's been folded on itself to make it look like the J that's sort of under your sink. Okay.
Right. It's like recycling.
And then it's sewed to the little bit of strip of rectum that's left just above the anus, just enough tissue to secure it in place.
Fantastic. And then once someone has this done, say if someone then developed issues in the anal area, would there then be an option to have an ileostomy done?
If people have a very high output J pouch, and despite dietary manipulation, despite using antidiarrheals like Imodium, Lomotil, or DTO, if they have really high frequency, so over 15, 20 J pouch movements in 24 hours, and it's very disruptive, and they're rushing to the bathroom and they have no control, then yes, the option is there for them to go back to have the ileostomy.
Oh, right. Great. Thank you for clarifying that. So then let's talk a little bit about the problems that someone might run into with a J pouch.
Sure.
Even like the problems post-operatively, and I think we even have a slide for that.
So people can follow along. The first one would be common immediate post-op problems, if you want to bring that one up. It should be right after those two pictures that.
Oh, right. Yes. Let me bring this. The stream.
Okay, great. So some of the issues that people may have immediately post-operative, and that's usually within the first 2 to 6 weeks, for example, is some frequency, stool consistency. It's usually loose to watery, a lot of urgency, some cramping, a lot of gas as the small bowel adjusts to yet another surgery. Borborygmi, which means really loud gurgling and grumbling. It sounds like really loud hunger pains, and some people find that to be a little bit embarrassing. People can get dehydrated initially if everything is watery and going right through them, no different than when you first have your ileostomy and you're trying to get used to that post-operatively. It seems like you drink water and it comes right back out. That's no different even with a J pouch. People will get perianal skin irritation, and that will happen because if the stool is really soft or loose and it splashes against the skin, there's digestive enzymes in it. So just like you would have peristomal skin breakdown because of leakage, the same thing happens around the anus. And then there's always the issue of small bowel obstruction. If somebody is a little too gung-ho and they eat a little bit too much fiber a little too early on, they may develop a small bowel obstruction. And part of the reason that people have problems with frequency and urgency is because in the beginning, the J pouch is a very small little tube, if you will. And as time goes on, we tell people to hold on to their stool. Like, don't sit down and go right away. Try to hold it for a couple of minutes before you go evacuate. And eventually it gets to be the size of like a large orange or a small grapefruit. So it becomes a better reservoir. So it holds on to stool a little bit better. And then the frequency issue can go away.
Oh, right. And so then in regards to outputs, initially, so I know like with an ileostomy and with other ostomies, like at the start, like the first couple of months probably post-op, your body's adjusting and then things kind of like simmer down. So that's kind of the same then when you have a J pouch.
And when patients have that temporary ileostomy, they have an idea about what is going to be going on when they get reconnected. So they're going to know things like they're going to drink and maybe take that fluid in with some crackers or a piece of toast to sort of absorb the fluid and hold it in place so that you can absorb a little more of it. They're still going to have to drink things like Gatorade, Powerade, Smart Water, Pedialyte, Enterade, other kinds of, sport drinks, things like, what's another one? Nun, N-U-U-N, that will help them stay better hydrated. And then we'll also offer patients the ability to use, anti-diarrheals. We don't like to usually do that within the first couple of weeks, no different than when you have an ileostomy, because we don't want to slow things down so much that you may have an obstruction. Right.
And I know we're not going to get into all of the dietary stuff today because that's a whole other topic. Right. But from what I understand from our earlier conversation, just like with any other ostomy, like meaning a colostomy or an ileostomy, the same things like being super careful, eating nuts and seeds, with veggies, like anything that's really stringy, and just really chewing your food well. So same protocol with a J pouch.
Correct.
Yeah, and keeping really well hydrated.
I remind my patients that your teeth are your best friend. And if you chew your food well and you don't eat too fast, then you should have, a good outcome.
Yes. I always remember going, because I was not great about chewing my food growing up in our Irish family. I think you're just like trying to get through your meal so that if there was anything left over, you're trying to get that seconds, be the first to the pot. So I just remember going like, oh my God, like someone told me, got to like you're meant to chew your food like 40 chews with each bite. I'm like, oh my God, but it works. It helps.
Yeah, it does help. And so when people have a temporary ileostomy, again, they learn that because they see the food come out whole, but it's no different. They'll see the food come out whole in the toilet, and it will be reminded to them that they really need to slow down and chew their food because they need to absorb the nutrients from it and they don't want to get obstructed.
Exactly. I want to say to anyone that is watching, if you have any questions, we always welcome questions, or I always love to know where you're tuning in from, or give us a thumbs up. But definitely, if you have any questions for Beth-Ann on this topic, feel free to put them up, and I'll check in on the comments here in a couple of more minutes. So then, in regards to frequency. So each ostomy is different. So with the J pouch, like how many times a day would someone normally, like if things are flowing correctly and working correctly, how many times a day would you be looking to go to the bathroom?
Sure. So after about 4 to 6 months, when the gut has adjusted and the J pouch is a little bit better of a reservoir, we'll tell people that about 8, maybe as many as 10 J pouch movements in 24 hours is considered within normal limits. And that will include, no different than when you have an ileostomy, the need sometimes to get up once or twice overnight to have a J pouch movement. But we tell patients that, if you eat later, the later you eat, the more likely it is you'll need to get up. If you want to try to take some Imodium or Lomotil right at bedtime, it might prevent you from needing to get up overnight. So, we have some tricks for things like that. But there's other concerns that sometimes patients have with their J pouches, which is some subsequent problems when it comes to nighttime stuff. And there's a slide that I have about that. If you want to bring that up, it's after the one with common immediate problems. It's some more subsequent issues that people may have and what we can do to help them with that.
All right. Do you know which number slide that is?
Well, see, on my slide deck, it was number 4. It says some common subsequent problems.
Yes.
Okay.
Let's bring that one in.
Okay.
Okay.
So one of the things that patients may end up having, and it can happen sometimes, 4 to 6 months post-operatively, sometimes, a year after, but is a condition called pouchitis, which is some inflammation in the lining of the pouch. And what happens is people say, well, initially I was doing pretty well, but now I'm having gas, I'm having a lot of rumbling, I have to run to the bathroom, and I'm going more often. It doesn't seem like my dietary manipulation was really helping. So we'll do a test, with a stool called a fecal-calprotectin, which is a marker for some inflammation. Or, we'll take a look up inside with the scope and we'll get a biopsy to see what's going on. And generally we treat that with antibiotics, okay? And hopefully people don't become antibiotic sensitive, dependent, but some people do. They need to stay on antibiotics consistently in order to have good J pouch function. And some of those antibiotics are listed here: Cipro, Flagyl, Suprax, Augmentin, Bactrim, doxycycline, or vancomycin. The other thing that we can tell people to do is to try, after we do a short course of antibiotics, is then to move on to some of those probiotics. And some of those probiotics, which of course are sort of more natural, things like Visbiome. Some people remember VSL number 3. Some people can still get it, others can't. So instead of that, we use Visbiome, which is the same basically as VSL number 3. It comes in packets. We don't have people use the pills or the capsules because they're going to go right through. So we have people, not the pills or the capsules, we have people do packets of them so it gets absorbed. And there's Gut Pro powder that has 8 strains of bacteria. PB8 also has 8 strains, and that's something you can get over the counter. Unfortunately, sometimes the better the probiotic, the more expensive it can be, but patients get such good quality of life from that they look at it like, it's better than taking antibiotics all the time, and so they want to try that. The other thing is, if you go back to that slide, is something called cuffitis. So where the small, that J pouch was attached to the top of the rectum, all right, to the top of the anus, is a little strip that's been left behind by the surgeon to sew it on. And that remains inflamed like you had your ulcerative colitis. Sometimes it takes 2 years for it to burn out. And so sometimes what we do to treat cuffitis is the same stuff we used to do to treat proctitis, which is some creams or foams that people will put up inside, or suppositories to treat that. And then along with, some nighttime frequency, if you want to go back to that initial, okay, so here's the cuffitis. So it's like I was saying, that transition zone between the J pouch and the anus gets inflamed. And sometimes if it gets really inflamed, people will have a little bit of a narrowing and start saying to us, it's so hard for me to evacuate my pouch. Like I'm just pushing and pushing and nothing's coming out. Or they turn around and say, I'm having a lot of urgency. I'm having pain and irritation in the anal area. And we have two ways of describing that. It can be a short course, which means, it occurs just for 4 weeks, or if it's a chronic problem, it lasts more than 4 weeks. And, it's based on the symptoms that people have. Plus, we can go in with the scope and take a look and see how inflamed it looks. So again, the treatment is some like Canassa suppositories, which some of you who have ulcerative colitis may remember using, a steroid foam, a suppository, or budesonide foam, or Euceris foam. We'll use those same things to get people some relief.
Oh, okay, great. All right. So I'm going to go to our comments and see if anyone has any questions. Okay. Let's see. I'm going to bring this in here. So Liza asks, will this be recommended for SCI patients?
What does SCI stand for?
I don't know. So Liza, if you're still watching and you want to type in what SCI is, that will be helpful because I don't know what it is. Okay, and hi Justin, joining us again. Thank you so much, and thank you. Justin helps with promoting and sharing a lot of the information about the show each week. So thank you so much for doing that. Let's see, I'm just going to bring in your comment in here. I had a J pouch from June 93 till July 97. I had to go back to an ostomy because my quality of life was very low due to soreness in the anus from going to the bathroom so much, despite being on 15 hospital strength Imodium each day. Mm-hmm. Yeah, so as you had said, Beth-Ann, that can happen, and thankfully there is that option then of going back and getting an ileostomy instead. Mm-hmm. Nurse Cheryl is saying hi to us. Hi, Cheryl. She's a nurse over at the BI. Laura says, thank you, that happened to me today. I have an ileostomy and the pineapple and raisins seem to come out whole. Mm-hmm. Yes, I need to do better. Yes, especially with anything that's, can easily sneak through. That's what you need to chew so much more.
Yeah, you have to really be careful with dried fruit and which raisins are. And then, as we all know, the pineapple is very fibrous, so you really need to chew those things well.
Yes, yeah. And over time, I know I've learned so much over time, and I'm sure it's the same with having a J pouch, mm-hmm. that your tolerance for different foods changes also.
Yeah.
That even at the start, if you're finding that you can't eat certain foods, I always encourage people, don't say that you can never have them, because you never know. A few years down the road, when your body is fully healed,
yeah,
you might have a different experience.
Right. And we tell people that if they try something and it doesn't work out well, don't give up the ship. Just give it up for a couple of months. Go back to it. And if it still bothers you, then maybe you can't enjoy that food anymore.
Exactly. Okay, so let's get back to some of the other things that we are going to talk about here. And please keep the questions coming. One more thing. So, you know what? So SCI might be for spinal cord injury. That's what someone else was saying. Let me just bring this comment in again. Will this be recommended? Will a J pouch be recommended for SCI patients, spinal cord injury patients?
Okay, so I think it depends upon if the patient has function of their anal muscles or not. So if that anal canal has been weakened based on where the spinal cord injury is, then I would say not, because they would just have continual seepage of stool out their bottom and have skin breakdown.
Right. Thank you. So let's go back to the other the other common problems that people might encounter?
Sure. So when you sleep at night, all of your muscles are very, very relaxed, including the anal sphincter muscle. So sometimes people get some nighttime seepage of stool. So what we recommend to people is, again, trying to take some Imodium or Lomotil to firm things up, because when stool is firm, it won't seep out. If people still have some seepage, then we'll tell them to put a cotton ball up against the anus to capture it so it doesn't break down the skin around it. Nighttime stool frequency, again, we already addressed the fact that if you eat after 8 o'clock, you might expect to have to get up once or twice. Maybe if you eat a very heavy meal or you have a very greasy meal, for example, fried seafood or something like that, then you may end up, waking up in the middle of the night to go to the bathroom because of that. And then people always have concerns over sexual relations, no different than for patients who have, a permanent ileostomy as well. I don't know if I have another slide here that we can go to about
We
that.
do, actually. And I know a couple of
there.
I'll bring up this other slide here about the sexuality.
Yeah.
I'll put that in. And we did have a show about, for women's issues, health issues, where we touched upon sexuality, sexual function with Crohn's, colitis, and ostomies. And for the fellas out there, I am going to have someone on to talk about male issues also. But in this regard, let's bring up this slide for sexual function for people with J pouch, some considerations.
Right. So we tell women to avoid intercourse for 6 weeks post-operatively, and we tell them that because the J pouch and the vagina are very, very close together, okay? And we want everything to heal up really well before there's, any pressure put on that area. And then 25% of women had occasional pain with intercourse. And it's funny that I don't know if this was, I got this information from UCSF, that's out in San Francisco. They have an IBD center out there. And they were the ones who said it affected younger women more so than older women, which I thought was very surprising. I haven't had that experience here. It's like, if it happens, it happens. And if it doesn't, it doesn't. And it was not dependent upon age. And men will notice some temporary changes in their erections because of swelling and inflammation around what we call the pudendal nerves. Men have very narrow pelvises, unlike women, because we have babies, right? And so it's harder for a surgeon to take out a rectum in a man than a woman because there's less room to work in. And regardless of the gender, when we're finished taking out that rectum, we want to make sure that people can get erections, can have orgasms, and can urinate. Okay, so it's a lot of work. There's a lot of nerve ending. And when there's this temporary swelling from the manipulation of the area, men may notice some changes, and also may take them longer to get an erection. It may not be as firm after surgery. And the older a man is at the time of the surgery, the more likely he may have even some permanent changes in his sexual function, which is another reason sometimes why we think about permanent ileostomies in people 65 and up. But it's uncommon for men to really notice that these changes are going to be permanent or really affect sexual intercourse for them. And anal sex is not recommended at all with a J pouch.
Right. That makes sense. I'm wondering, is there more of a population of women that end up getting a J pouch versus men?
No, it really depends upon how severe the disease course is, or how much at risk they are for developing colon cancer, or if they've already had some precancerous changes, or if their disease is really resistant to a lot of the medications that we use to treat the ulcerative colitis. It's not more men versus more women. It's just very bad disease.
Right. I was even just thinking in regards to, if there can be more sexual problems down the road for men versus women, if that might be a consideration to have an ileostomy versus a J pouch. And for anyone watching, like if you are like in the time of making these decisions, then this would be something to talk to your doctor, to talk to your team about, because you want to make sure that you know what you're getting in for when at all possible. And as always, we're just here, and Beth-Ann is giving this information, and this is like educational information, but always consult your own team, because we don't know your history. So that's why it's really important to get ideas from what we're saying, but consult your own team as well. So Beth-Ann,
No, but I just wanted to interject with one other thing. I know that you had my colleague Sonia Friedman on, one of the physicians that I work with, and she probably talked about, I'm just imagining that she probably talked about pregnancy and IBD. Was that her thing? Okay. Yeah. So did she already talk about fertility issues?
Yeah.
I don't talk about them with J pouches though.
Yeah, could you tell us a little bit for J pouch? I mean, we kind of kept it more general in regards to ostomies and like Crohn's and colitis, but yeah, can you tell us about the J pouch?
Yeah, so generally what we tell young women of childbearing age, because as we all know, inflammatory bowel disease tends to affect younger people. And so if we have a woman of childbearing age who needs to have a J pouch, of course, one of the things that she's concerned about is, will she be able to get pregnant? So what we tell these women is that after 6 months of trying, if they don't get pregnant, then they need to see a fertility specialist. They don't have to wait a year like they would if they had never had any surgery to their abdomen or pelvis. So that's really important. Now, we've had women get pregnant naturally without any problems, and we've had women who've gone on to use IVF and they've gotten pregnant successfully, and all of these women have carried to term. We do recommend that patients have a C-section, because passing a large baby through the vagina can really disrupt the J pouch. And if there's a tear, between the vagina and the anus, it could potentially destroy the ability for that person to hold on to their bowel movements and really weaken that sphincter muscle. So they have a lot of problems with incontinence postpartum.
Right, thanks. That's really helpful, because I know with having the other ostomies, the one thing you're trying not to do is have a C-section. So for anyone that was watching a few weeks ago, I know we had brought that up, and that would be a complication. So the complete opposite now in regards to having a J pouch, a C-section would be what you would go for, and that makes so much sense.
Sure. Okay.
Yeah. And then in regards to women, like when they are pregnant with having a J pouch, does it feel like any different? Does it put on is there like a lot more pressure then coming down through the J pouch, I would imagine?
Right. So what can happen is, as the baby gets bigger and takes up space, it crowds out the J pouch a little bit. And some women do complain of needing to evacuate more frequently.
Right. Okay, so let's just go back and see if there's any more comments. I see my sister, who you work with as well, Janine, is saying hi. Hi, Janine. Oh, thank you. Allison is also saying great work we're doing here. So yeah, keep the comments coming, and I do check in on this after. So if you're watching this on the replay, you can also put up any comments or questions. I can reach out to Beth-Ann anytime if you do have any specific questions. So Justin has another question here. Let's see if we have any insight. I have a neuropathy under my stoma, and I'm now on 600 milligrams of, I can't pronounce that, gabapentin 3 times per day. Have you heard of others with an ileostomy having neuropathy around the stoma? Have you heard of it?
No, not around the stoma, but we do have some patients who end up having some, more permanent abdominal pain that we do realize is neurologically involved. So we do put them on gabapentin for their abdominal pain that's happened to them post-operatively.
Right.
So it might be the same kind of process where there's some nerve damage just from all of the surgeries.
Right. Oh, okay, great. So anything else that we have missed? Anything else? As I said, we're not going to get deep into all the dietary stuff. But then the other insight for people getting a J pouch or that might have a J pouch?
Yeah. So if you look on, I don't know if you have page 7 there for medications and supplements, if you want to pull that up a little bit.
Sure.
And some of this is really no different than patients with ileostomies, what they face. So if people have a lot of output, they can use the antidiarrheals, and it goes up in strength, Imodium being the least strong, moving up to Lamodal, and then the strongest, which is tincture of opium. And we will move people up the ladder, and we will give them the maximum dose of all of these medications if needed. But if they still say that even though their stooling is now slowed down, they still have liquid stools and it's burning the anal area, then we'll ask them to use some form of soluble fiber. And my favorite actually is to go to Citracel. And Citracel is made out of fruit pectin, so it doesn't cause gas because it's not made from wheat like Benefiber, Consul, or Metamucil. However, I have patients who travel a lot. I have a patient who's actually a pilot with a J pouch, and he has to do transatlantic flights. And his secret is to eat 2 Metamucil wafers, drink 8 ounces of water, and do that about an hour before he gets behind the cockpit and takes people on their flight safely to places like Ireland and England, for example. So everybody has a different way of keeping things firmed up. So, keep an open mind, and those Metamucil wafers, they're like cookies. They taste kind of good, but I find they stick to your teeth.
Oh, right.
That's his secret. So, yeah.
Okay, great. Another question just popped into my mind is, so if someone gets a J pouch because of IBD, then when they have their J pouch, are they going to be symptom-free then?
Well, again, they may not be, because they can develop pouchitis or cuffitis. And so they will have increased frequency, increased urgency. They might even see a little bit of blood because the cuff is inflamed and will bleed a little bit.
Okay, great. And then typically if someone has a J pouch because of IBD, do they still need to take any medications? Like, say if they're not having any symptoms, can they usually come off all medications?
Right. They usually, before they have their surgery, we want to try to get them on 20 milligrams of prednisone or less. And we try to stop one of their biologics like Remicade, Humira, Entyvio, Stelara, try to get them as far away from their last injection or infusion as possible so that there aren't post-op complications of people not healing up or developing infections. But people get to come off of all of those medications. But that said, sometimes we have people who have chronic pouchitis, and even despite cycling through numerous antibiotics, still have problems with that. We will actually put them on the biologic called Entyvio, which is an infusion, which has worked very well. It's considered off-label. We have to you will always carry the diagnosis of ulcerative colitis with you, and the insurance company just sees that we've labeled you as that, and they will approve the drug. So we can get people under really good control. And there was a young woman that I took care of who had her first baby while her colon was still intact. And then she had a J pouch and developed really severe pouchitis and really wanted to have another baby. And we cycled her through antibiotics, and you can't be pregnant and on a lot of antibiotics for a long period of time. So what we did was we put her on the Entyvio, and she had what we call an Entyvio baby. So she ended up getting pregnant, carrying to term, and have a beautiful baby, despite all of the problems that she had with her pouchitis.
Oh, that's really inspiring. That's fantastic. So I think I don't see any other questions right now, but that's like so much information for everyone. So thank you so much, Beth-Ann. It's lovely to see you.
Yeah, thank you for having me. It's nice to see you too. But
yeah.
nice to see you not in the office.
I know. You know what I was just remembering? It was coming into my head there. I'm nearly sure you were the nurse in the room. I'll share this little story because I went to see Dr. Josh Korsnick, who's one of my wonderful doctors as well. And it was before I was trying Remicade, but I was trying an injection. Oh my God, methamphetamine. I can't remember. It was an injection, and I'm like terrified of needles. Like can't look at anything. I'm so not the nurse in the family. And I'm sure it was you in the office and Dr. Korsnick. I always have to say his name with a Scottish accent. But you know, your practice, getting me to practice, like putting it into an orange, like with a pen and whatnot. And then like with the real injection, I had to give it to myself in my thigh. And I was so nervous that it went like fumbling out of my hand, crashed on the floor, and it was basically probably like $500 worth of a drug that just smashed on the floor. I was like so embarrassed. I'm nearly sure it was you in the room. Like this is like 15 years ago. I was just
okay, it happens. People get nervous about it. But
so,
the delivery system now is much better with the Humira than it used to be. So it's not as hard. Yeah.
Yeah, that was many moons ago.
Yeah.
But thank you so much for your time. I'm going to just go back to I'll talk to you in a minute.
Thank you for having me. Thank you
for imparting all of this amazing information to us all. So everyone, thank you so much for joining me once again. If you are interested in my free guide, I have one for people with IBD called 5 Mistakes Even Well-Informed People with IBD Make, and you can jump onto my website, elaineo'rourke.com, and grab hold of that. And I have another one for people with ostomies. It's called 3 Ways to Eliminate Fears About Your Ostomy. So again, you just go to elaineo'rourke.com and you can grab hold of that information. Next week, I'm going to have Nurse Anita is going to be back on the show again. She's a hoot. So if you have any questions, so she's an ostomy nurse. If you have any questions even in advance, you can send them along, or just be ready next week to pick her brain with any specific questions about ostomies, and we'll just be having a conversation about further things that go along with having an ostomy. So remember, hop onto YouTube, tell people about the work that I do. And also in the new year, I'm going to be starting a new program for yoga for people with ostomies and IBD. So if you're interested in that, send me a message and I will send you that information. So in the meantime, please be well, and I will see you next week live at 5 East Coast America time. I'm still in this country for another few weeks. And in the meantime, take care of yourselves.